Okay, so I can see a number of familiar faces in the audience, but there are also some new people. So I'm going to start from the beginning, but I did think that actually I might pick on a couple of people to give the first part of my talk because they'll have heard it about 10 times or 11 times, but I decided not to do that. So I'm going to give you a general update about IgA nephropathy and what's happening in terms of new treatments. So we have two kidneys. Those kidneys filter our blood every second of every minute of every hour of every day of our life. And the kidneys are constructed of filtration units. And each of those filtration units is called a nephron, which is why I'm a nephrologist and you go to the nephrology department. And that nephron consists of a filter, which you can see here, and that's called a glomerulus. And blood comes in here under high pressure, fluid is squeezed out of the blood, and the remaining blood goes back into the body. And that early fluid that's squeezed out is the urine. And the urine then goes along this tubule and gets modified with things that we need brought back into the body and things we don't need passed into the urine, and then we get urine at the end of the day. So this is the major filtration unit. It's called the glomerulus, and a disease of these glomeruli, you just see this has stopped working. Oh, there we go, are called glomerulonephritis. So you might go to a GN clinic, a glomerular disease clinic, and IgA nephropathy is just one type of glomerulonephritis. And one of the things when we ask patients about what frustrates patients the most is the amount of jargon we doctors use. And we often use jargon because it makes us look very clever, but it's also not very useful if you have no idea what we're talking about. So IgA nephropathy is a disease of the filters. The filters are called glomeruli, and it is a glomerulonephritis, and the itis means inflammation. So that's what we've got. It is an uncommon disease, a rare disease, which is why most of you may never have met another patient with IgA nephropathy. And it's usually not what us Brits do, which is when we're sat in a waiting room, we usually don't talk to anyone, do we? We sit there down. So we have no idea who else has the disease. And it's not something you're likely to come across. You'll know someone with diabetes, you'll know someone with asthma, you know someone who may have had a heart attack, but it's not something that you will know much about and the general community will know much about. And one of the frustrating things is you tell someone you've got IgA nephropathy, they'll look at it and they'll say, well, you look completely fine. There's nothing wrong with you. So you hear that all the time. So it's really challenging to find, for people to understand who you're talking to, what it means to have IgA nephropathy. And I think one of the things is to access and have opportunity to talk to other patients. So certainly this is no different in the United States as it is in the UK. Everything I hear here, when I go to the US and we go to the meeting that you guys run, I just hear it in a different accent. It's exactly the same challenges. So it's an uncommon rare disease. So hands up who's had a kidney biopsy. Keep your hand up if you enjoyed the experience. Okay. Well, I've done lots of kidney biopsies and it never caused me any problem. But you can only diagnose this condition with a kidney biopsy. Here you can see it being done. That's the little bit of tissue we get. And what we do is we look at that under the microscope. We have two kidneys. I'm often asked, is the disease present in both kidneys? Because you only biopsy one kidney, and it is. We generally biopsy the left kidney because the liver's on the right-hand side and it gets in the way. So it's just a practical thing. So this is what your kidney biopsy will have looked like under the microscope. See here, those are the filters, the glomeruli, nice balls of cells. You can see here, 1, 2, 3, bit of one there and one there. And this is where all the mischief is happening in IgA nephropathy. And these here, these other structures are those tubules. And you can imagine cutting them across. You've just got a nice round circle with the urine going down the middle. And in IgA nephropathy, when we look at these filters and we stain them, every single one of these filters lights up with the protein IgA. And you can see it stuck in all of the filters, every filter in both kidneys. This is the chap that first described the disease. He's called Jean Berger. He was a Parisian pathologist. He described it for the first time in 1968. because he was the first one who was able to stain the kidney for IgA. So many of you will do a Google search and you'll see Buerger's disease or Buerger's disease. That's what it used to be called. It's exactly the same as IgA nephropathy. We've just changed the name. That protein is an antibody. We all have antibodies. They're very, very important to fight infection. But in IgA nephropathy, the antibody is actually causing the production of big clumps of proteins that deposit in the filters. And this is the IgA antibody. We've got 5 different types, but for IgA nephropathy, this is IgA. And IgA is produced by cells of the immune system, and those cells are called B cells. And so when we think, and I'll come on to the kind of treatments we're looking at, what we're trying to do is target these cells to stop them producing the IgA that ultimately ends up in the kidneys. So this is something that is part of your immune system. It's very subtle. It doesn't mean you're more prone to get infections, but it is a subtle change that means that this IgA protein is going into your bloodstream, producing these big clumps of proteins that then deposit in the filters. And when they deposit in the filters, they can cause lots of inflammation. And where do we think these B cells live? Well, we think these B cells live in what's called your mucosa. And this is the lining of your respiratory tract and your gastrointestinal tract. So the IgA that we normally have is very important, and it's in our sputum, our tears, our respiratory secretions, our gastric secretions. It just sits there waiting for bacteria to come along, and it attacks the bacteria and stops them entering the body. And that's the normal role of IgA. In IgA nephropathy, we think these cells are slightly misbehaving, and some of that IgA that should be fighting and stopping bugs coming in ends up in the bloodstream. And there it causes these protein clumps to form. So when we look at these IgA, what are they doing in the filters? Well, what they're doing is causing all sorts of mischief, and they're causing inflammation. And that inflammation is damaging to the filters. And if that inflammation isn't controlled, you'll end up with those filters becoming scarred and not working anymore. And so there's a lot of work looking at what is driving that inflammation, because we can potentially block it with drugs. Again, I'll talk about that in a minute. The major driver for that inflammation is something from what's called the complement system. This is another bit of your immune system. And this is like the infantry of your immune system. This is out there all the time, just looking for trouble. And if trouble comes along in terms of infection, it responds within seconds to try and kill those bacteria. So it's there, everyone has it. It's a very, very important part of our immune system, and it's just waiting. It can respond within seconds to a bacteria getting into the body. It'll identify that bacteria and it will kill it while we're waiting for antibodies to develop. The problem is it can also get activated by those clumps of protein, the IgA that's depositing in the filters. So that's not what it's supposed to do, but it does do that because those clumps of protein are there when they shouldn't be. And that's important because we've got treatments now that can affect this. So what happens in those filters when you have those IgA deposits? Well, those filters can get damaged, and the early signs of damage are that we can see blood and protein in the urine. You will not see it necessarily, but we will see it, particularly with a dipstick test. And this is something that's very important in identifying early damage to the filters. If you imagine the filter as a sieve, that damage makes those sieve holes bigger. Now, normally we wouldn't see any blood in the urine because the blood cells are too big. And normally we wouldn't see any protein in the urine because the filters are doing their job. But when the filters are damaged and the holes of those sieve get bigger, then blood and protein can leak in, and we can detect it on a dipstick. Some people may actually see blood in their urine. As Bonnie said, her son, it's very much more common in kids than it is in adults, but often with a cough or a cold, patients may notice they're passing either blood, urine that looks like blood, or Coca-Cola or tea. And that's quite common. It stays for 48 hours and then it'll go away by itself. But it's not generally common in adults, although some adults do experience it. But what we are looking at, and you will know full well that every time you go to clinic, your urine is being dipsticked, and nephrologists are looking to see whether there's blood and protein in the urine. And then we will quantify how much protein is in the urine by doing you'll provide us with a urine test, and we'll do something called a PCR or an ACR, which is a protein to creatinine ratio or an albumin to creatinine ratio. And that's what we'll do to monitor part of your kidney function. And what we want is to have as little protein or albumin in the urine as possible. So we're looking at that first as a marker to see how severe the disease is, but then is the treatment working, and is the amount of protein in the urine going down? I mentioned that we think the cells that produce the IgA are within what we call the mucosal immune system. So whenever your mucosa gets activated, so you pick up a cough or a cold, you have tonsillitis, you have a gastrointestinal infection, that immune system gets hyperactive. And whatever it's producing, we still don't know, is ending up making the nephritis, the inflammation, worse temporarily. When that infection goes away, the signals go away, the kidney gets back to where it was before. So we see this quite commonly, particularly in children, as I say, but often in adults as well. Most children grow out of it, but we still don't really understand why that is the case. Ishika's PhD is actually going to be looking at taking a group of patients who have these flares of disease. Often people will complain of pain in the back as well at the same time. So we're taking people who have those episodes, bringing them up to Leicester, they're asking for lots of blood, lots of urine, lots of other bits and pieces, and we're going to scan your kidneys. And by doing a detailed scan, we can work out exactly the volume, how big your kidneys are. And then we're going to bring you back when you feel completely well. And we're going to repeat all of it so we can work out what's changed between those two, because we really don't know what it is that is happening that gives you this flare. One of the ideas is that the loin pain, the pain here that a lot of patients with IgA nephropathy complain about, is because the kidney is going through a temporary period of intense inflammation. And so the kidney gets bigger, it gets swollen, and that's what gives the pain. Yeah, the filter's normally very good, but they can get bigger and they can get smaller. It's not a fixed, rigid, like it's made up of cells, and it's made up of things that can move. So that's something we really don't very well understand, but it's something that Isha's going to spend the next 3 years of her life looking at. And she's really excited about it, aren't you? So over time, this blood and protein in the urine can eventually lead to the filters becoming damaged irreversibly. And one of the things we see is the development of high blood pressure. So nephrologists are obsessed with your blood pressure. All my patients, I ask to get a blood pressure machine at home so you can keep an eye on your blood pressure, because it doesn't generally give many symptoms if your blood pressure is high. And so damaged kidneys cause the blood pressure to go up, and high blood pressure damages the kidneys. So you can imagine there's this vicious cycle where you may not know what's going on with the high blood pressure damaging the kidneys, that making the kidney function worse, making the blood pressure higher. So we need to take a very careful eye on what the blood pressure is like, and we want to make sure that is optimized and controlled as well as possible. But that is an early sign again, but it's silent. So most of the time, so I'd be interested here, how many people got diagnosed with IgA nephropathy completely by chance? They went to see a doctor, and actually they weren't going because their kidneys were a problem. They went in and that someone did a test or something, and they went, bloody hell, something's going on with the kidneys. So lots of hands going up. That is the commonest presentation we see, because by and large, this condition does have no symptoms. And that's what's really frustrating, because by the time patients come to us, there's a lot of mischief has already gone on that potentially we can't put right. So the IgAN Foundation are doing some really interesting studies at the moment where you're going out into the community and dipsticking people's urines and seeing what the likelihood is of picking up disease in asymptomatic people. It's much better for me to look after a patient if you come to me with completely normal kidney function, rather than you coming to me late where there's a lot of damage already and I'm having to work with trying to get the remainder of your kidney to last as long as we can. So one of the things we're really challenged with at the moment, and what we're thinking about how we might deal with, is how do we find patients with IgA nephropathy sooner? And that'll become even clearer when I show you all the new treatments that are coming. And then, of course, sadly, as those filters become scarred, they don't work, and the kidney function starts deteriorating. And so to understand what happens when the kidney function starts deteriorating, we need to understand what the kidneys do in healthy people. So kidneys are very important in controlling blood pressure, as I've said. Kidneys are very important in controlling how much salt and water we have. Very important in controlling and getting rid of all the excess salt and water. And if your kidneys can't get rid of salt and water, you swell up. So one of the things a nephrologist, you come into the room, the nephrologist is straight away looking at your ankles because they want to see whether you're carrying extra fluid. And that's extra salt and water because the kidneys haven't been able to get rid of all the salt and water that you've had in your diet each day. And of course, one of the things we see is the water goes wherever gravity sends it. So if you're up on your feet all day, the water's down in your legs. If you get up in the morning having lie flat, your ankles are nice and slim because all the fluid is here because you're being lying flat. So that's one of the things we look out for. And if you have too much salt and water in the body, your blood pressure will go up. So that's one of the things we need to look for. The other things are that the kidneys get rid of all the extra salts and chemicals that we take in with our diet every day. So we get rid of potassium, we get rid of phosphate and acid. And so one of the things we look at on your blood tests, particularly when your kidney function is getting low, is are you accumulating any of those? Because those can cause problems. So that's something we're looking at. But this is when your kidney function, your GFR is getting down into the 20s. Not something that we tend to think about if your GFR is 30, 40, 50. So this is something that we want to look at. And then the kidneys actually have a hormone function. They're very important in keeping your bones healthy and generating vitamin D and keeping your blood count normal. They generate a hormone called erythropoietin that stops you from becoming anemic. Again, these become an issue when your kidney function gets down to around 20-ish or so. So we have changes in kidney function. So hands up who rigorously wants to know all their clinic blood and urine results and keeps a track. Excellent, good. I was throwing how many have patient knows best? Good, excellent. So you can have a look. You probably see your results before I do. You've just got to be, so sometimes the patients find it quite frustrating when a test changes and the nephrologist says, don't worry about that, that's probably nothing. We'll just repeat it. One of the things to understand when you have your blood tests particularly and your urine tests is things outside of changes in your kidney function can change the way your blood tests look. So if we look here, whoops, where's it gone? So if we look here, you can see here that we're talking about deterioration of kidney function and we're looking at different stages. So presumably on your clinic letters, you may have your CKD stage 3 or 3A or whatever it happens to be. We define that, as you can see here, with the CKD stage 1 being above 90, but having something else like protein in the urine. 90 to 60 is 2, GFR of 60 to 30 is 3, 30 to 15, 4, and below 15 is CKD stage 5. And we do that because that helps us understand where you are in the natural history of the disease. And over time, things may change. We start thinking about dialysis and kidney transplants when you're getting to close to 20. So certainly, and you may actually transfer to a specific clinic, an advanced CKD clinic, which is set up for that transition between having kidney function that's a bit higher and planning and giving you information about what the options might be in terms of dialysis options and transplantation. So ideally, we never want a IgA nephropathy patient to ever know what this machine is. It's a dialysis machine. if it comes to it, what we would preferentially want to do is to think about a kidney transplant. And there are a few people here that have got kidney transplants, but that would be the preferred option if we're seeing the kidney function deteriorate. But often that may not be feasible straight away, and there may need to be a temporary period of dialysis. Everyone's kidney function changes at a different rate. And that's just naturally because the disease is very different in different people, but also depending on the treatments that you have access to can slow the rate of loss of kidney function. The combination of treatments can do that as well. So that's something to be really clear about, is just because the person sat next to you's kidney function went down very quickly does not mean that yours will. You will be very particular in terms of what happens to your kidney function, which is why keeping a track of your own blood results is really important. So we have a typical English summer day here, and we have a typical English summer day in, let's say, California. A couple of weeks ago, you had quite hot weather in the UK. I guarantee you that if you had had your preclinic bloods done on that day, your creatinine might have been a little bit higher. Because if you get dehydrated, your creatinine will go up, your GFR will go down. Or someone changes your tablets. Your creatinine could go up, but doesn't mean your kidneys are working less well. It's just a function of what we use to measure your kidney function. Anyone know what that is? The most popular UK meal at the moment? And you're in Leicester? Chicken tikka masala is the most popular dish in the UK. Depending on what you eat, and here is what we eat generally when I go to the States, a lovely big steak with loads of extra salt. If you have either of those two meals and then check how much protein is in your urine, it will go up. If you're a runner and you check your bloods and urines after you've been out for a run, they will go up. Which is why when we're looking at blood and urine results, we look at them, to say with a pinch of salt, but we look at them in the context of what you've been doing. Yeah.
Is it the same if you go like a gym exercise?
Yeah.
You mentioned runners, but what gym exercise?
Yeah. So if you do vigorous exercise, you do your proteinuria, your protein, say for a week of just gentle walking, whatever, and then you urine protein and do some vigorous exercise in the gym and do protein, the proteinuria will be higher. We know that.
Is this damaging?
No. It's just that we have these tools that we use to measure your kidney function, but they're not infallible, which is why they need to be interpreted, which is why I tell my patients, please don't get distraught, because with Patient Knows Best, you have your clinic bloods done a week before clinic, before you see me, and you'll see them immediately on your app. And if you see a slight change in your creatinine or proteinuria, that can ring massive alarm bells. But actually, when I look at it, I'm pretty relaxed. So we need to educate patients to understand it doesn't necessarily mean that things are changing in a bad way. You know, you might only have your blood test done once every 3 months, but that period before your clinic appointment can become a very stressful time. And the bottom line is, if there is a significant change in your blood tests, your nephrologist will be informed because the lab will generate an alert and we will see. But of course, if you are concerned, the easiest thing in the world is to chat to your nephrologist. And the easiest thing in the world for me to do is just say, come and have another blood test because it's likely to have changed and gone back to normal. So don't sit on things and worry, but understand that actually we will be a little bit more lackadaisical about what we see as a small change. There's likely a very clear explanation. So treatment. So when I see a patient, they're sat opposite me, what am I wanting to treat? And that may sound a strange question, but what I want to treat is all the things I spoke to you about. Stopping this protein, this IgA protein getting stuck in the filters, try and target those cells that are producing it, and try and limit the mayhem that is going on in those filters because of the IgA. But we also need to understand that as you lose filtration units, the remaining filtration units are working harder. And that's a different kind of set of processes. And I need to think about treatments that help me manage this as well. And they're different treatments, and I'll talk about those in a minute. And then I also need to think, is there anything else going on that could be compounding your risk for progressive loss of kidney function? And here we're talking about, might be talking about, we'll have a look. I stood too far away. I think I'm stood too far away. Controlling your blood pressure. We know irrespective of what you have, high blood pressure damages kidneys. So we're going to be obsessed about your blood pressure. We want you to be as generally healthy as possible. And you may have other conditions that separately damage the kidneys, like diabetes. So all of these things are things we're thinking about when you come in. We want to have treatments that target the IgA nephropathy process, treatments that help with kidneys that are in trouble, and thinking about things that might also be adding to the risk of progressive loss of kidney function. So this was what it was like when I wanted to treat IgA nephropathy for about the last 25 years of my career. There was nothing really to use, and really there was no interest in the pharmaceutical industry to develop new treatments. But thankfully, that has completely changed. And this is perhaps a strange thing to say, but if you have to have IgA nephropathy, now is the time in the last 50 years to have it, because we have so many wonderful new treatments coming. So we now have almost a full drug cupboard, and that's getting fuller. This is me, or Harish, or Chike thinking, what the hell is happening? And also, this is you, because my guess is you love Dr. Google, and you will search the internet, and you will hear people talking about all these different treatments. And the common question is, what am I going to have? What's right for me? Why am I having this one? Why should I not have this one? It's a very confusing time, but in a good way. So, in the United States, which is where drugs generally get approved, so the process of a new drug is we do the trial, we present the data to a regulator that checks whether it's safe and effective, and that regulator, which is a government body, then says, yes, it is appropriate for that drug to be used in this particular country. And the body that does that in the States is called the FDA. The body that does it here is called the MHRA, and in Europe it's the EMA. And every country has its own regulator. And you have to take all of that data to each individual country, for each individual country's regulator to say, yes, we believe it is safe and effective, and it is allowed to be prescribed in that country. The next thing is who's going to pay for it. So in the UK, we have well, in England, we have NICE. NICE will take a look at the drug and work out whether it's cost effective. And if it's cost effective, I can prescribe it as part of the same as any other tablet. So in England, MHRA approve the drug, NICE say we can prescribe it, and then we can prescribe it. And it's different processes in different parts of the world. But generally, most drugs are approved in America first. So in America, they have 5 drugs at the moment, and all of these are likely to come our way. There's another 3 that are going through the review process at the moment, where the data's been submitted and the FDA are working out whether they're safe and effective. So that's 8 drugs. There's 4 late phase clinical trials that will be submitting data to the FDA within the next 12 months or so. So that's 12 drugs. And then we have 2 treatments that are just about to start the trials to get the data to go to the regulators. That's 14 drugs, and there are more in the pipeline. So we have gone from a very empty drug cupboard to an overwhelming drug cupboard. And many of these drugs do very different things, which mean if drug A doesn't work for you, I can try drug B. And if drug B doesn't work, I've got drug C. And if none of those work, I'll put them together. So this is a fantastic time to be thinking about how we might treat IgA nephropathy. And for those of you with kidney transplants, there is a potential that this can come back in the kidney transplant. All of these drugs are likely to be useful to control the disease if it comes back in a transplant. But it does take time, because each of the companies is going to be putting all this, I mean, this is a big amount of work it takes to put all the data together for the regulator to be able to look at and say, yes, it's safe and effective. So we are seeing things moving from the United States across to Europe, to Asia, but it just takes time. And of course, you're going to be very frustrated about that, but this is the way the world works. So what do we have in the UK and Europe? So at the moment, we have 2 drugs. We have the first 2 drugs to be approved in the United States are now here. Nefecon, which is a gut-directed steroid, and sparsentan. They're approved in Europe by the EMA and in the UK by the MHRA, and both are approved by NICE, so I can prescribe them in my normal clinical practice as long as patients reach certain criteria in terms of GFR and the amount of protein they have in the urine. So we have these agents, we're waiting for these other agents to come.
You know, these criteria, is it to do with EGFR and the amount of protein that you are leaking? So why would you not do it earlier?
So it's different in different countries. So here, the approval in Europe and the UK is based on the criteria to get into the clinical trial in the first place. And the NICE approval is based on that. And to get into those clinical trials, you need a certain level of protein in the urine and a certain level of kidney function. And that's where they think the evidence is, and that's what they've approved. So that's the rationale behind that. I don't think it's right, but what companies are doing now is saying, okay, we need to look at the populations of IgA patients that weren't included in our trial to provide evidence that they still work if you've got less proteinuria, you've got a lower kidney function, you've got a kidney transplant. And we're starting to see that happen. So we have 2 trials open in Leicester now for patients with IgA nephropathy with recurrent disease. One that Chike is running of sparsentan drug, and one that is organized by a company called Pioneer that is looking at a new therapy in the context of recurrent disease. So it's coming. It's just people are starting with the general, straightforward IgA nephropathy population.
Yeah, I feel a little bit left out now.
Yeah, and I think so we as nephrologists want to use these drugs in anyone who we think is at risk. But the regulators have their viewpoint, and we keep arguing, but but the other opportunity then is to think what clinical trials are happening that allow us to bring patients into the study.
Are you able to say what the parameters are with regards to GFR?
So for both of them, it's more than a gram of proteinuria and a GFR above 30. So that was the criteria to get into the trial, and that's what NICE have said you need to meet for me to be able to prescribe the drug for you. But the trials that are doing studies have different lower criteria. So that's why it's always worthwhile thinking, okay, they say you may not be able to access this, or you're a patient group that didn't quite meet the criteria. There are trials now opening up for patients that didn't meet those criteria. And the good news is many of these trials are not comparing against a placebo. You're absolutely getting the drug. So it's not a risk of a 50-50, you're absolutely on the drug. So how do we target these cells? And what drugs are there? Because the rationale is if we can target these cells, we can limit the amount of antibody, we can prevent that deposition and everything else that follows. So we have 2 drugs. We have Nefecon, which is available here. And so this is the drug name, which you may or may not know. This is the trade name. So very confusingly, in England and Europe, it's called Kinpeygo. In America, it's called Tarpeyo. This is available. I'm prescribing it a lot, and we can use this to treat IgA nephropathy. The other drug that's available, which is approved in the United States only at the moment, is sibeprenlimab, and that's called Voyxac. I don't know who came up with these names. I mean, these names are bad enough, but someone will have been paid millions and millions of dollars to come up with a really catchy name that means something. I haven't got a bloody clue what that means. But anyway, so that's coming. That's being used in America at the moment. That will be making its way across the Atlantic. We then have 2 drugs that are currently sat with the FDA that are next coming, and that's why they're in the blue box, is they're not available to anyone yet, atacicept and povetacicept. And at the moment, we don't know what they're going to be called, because generally the companies don't say what they're going to be called until very close to their approval. So these trials have reported early data, the data's with the FDA, and this drug is potentially going to be approved next month. And again, these will be making their way to us in the near future. And then we have 2 drugs, and the names get even better, don't they? I spend most of my life practicing each of these drug names, so I don't look an idiot when I'm stand up talking about them. So these actually are in clinical trials at the moment, so they're a bit further behind. That's felzartamab and mezagitamab, and again, they don't have any other names at the moment, but they will get them in due course. And we are recruiting to both of these studies in Leicester, and there are other sites around the UK that are recruiting to these trials as well. So anyone interested, please have a chat with me or Chike or Harish, but these 2 trials are recruiting at the moment. And then how do we deal with that inflammation going on in the kidneys that occurs in response to those IgA molecules getting deposited? So here we're talking about targeting this complement system, this system that really responds to things very, very quickly. And we have one drug that is approved in the United States and being used called iptacopan or Fabhalta. So that's available in the US, may well be coming here. There is another drug called ravulizumab that I actually presented the data for this trial yesterday at the European Renal Association, showing that this drug reduces the amount of protein in the urine. We've been doing this trial in the UK. It already has a name called Ultomiris because it's actually used to treat a number of other conditions. So it's already being used in the UK for other conditions, including some very, very rare kidney conditions. And then we have another drug called cefaxacen, which is still in clinical trial, but has finished and is now we're waiting to see the data. So you can see there's lots of different ways that we are able to target these different processes, and each of these does something slightly different. So if one doesn't work, we can potentially think about the other. What happened there? Okay, so now let's think about how we deal with a kidney that's in trouble, generally in terms of the fact it's lost a lot of filtration units. And when you think about losing filtration units, as with anything, the remaining filtration units have to work harder. So you start off with 1 million filtration units in each kidney and you get down to 500,000. They're having to do the work of at least twice the amount of work to deliver the same effect. And of course, when these filters are doing more work, they become more fragile and they're more prone to break. And we know that's not specific to IgA nephropathy, it's common across all diseases. And what is driving that hard work in those filters? It is 2 chemicals, predominantly angiotensin and endothelin. And so one of the rationales across many forms of kidney disease is actually to protect those filters from overworking, is to block those chemicals. And I guarantee every one of you in the room with IgA nephropathy, I would imagine, is on either a drug that ends in pril, lisinopril, ramipril, or a drug that ends in sartan, candesartan, losartan, because those drugs target the angiotensin side of this. We've never been able to block the endothelin side of this equation, but we now have 2 drugs that allow us to do that. The first is sparsentan, which actually combines blocking angiotensin with endothelin. So if you're on this drug, you don't need to be on a pril or a sartan. You're just on this. And this is called Filspari. And this was the second drug to be approved for IgA and is available for me to prescribe in the NHS. Some of you may be on it. And the other drug is a drug called atrasentan, which just stops the endothelin, and then you add it to any of the other prils or sartans that you're on. That's called Vanrafia, and that's available in the US and may well be coming to us soon. So we have these agents now to help us deal with those overworked, hard-working filters that we want to just give them a little bit of a rest and protect them from further injury.
This is something to bring blood pressure down.
Yep, it will bring blood pressure down as well. So, and that's the thing, whenever we start sparsentan, we always start at a 200 milligram dose, check the blood pressure's okay, and then bring it up to the 400 milligrams and keep an eye on the blood pressure. We may even stop some of the other blood pressure medications to give room to give the sparsentan. So we clearly have a lot of treatments coming, and that was a whistle-stop tour, and Chike is going to go through a lot of this again, just to remind you about what's coming. But there's always the option of a clinical trial. And so anyone in the room, it's always something you should think about and talk to your nephrologist about or talk to us about, because there are clinical trials happening. They're an opportunity to access new treatments, and it may or may not be appropriate for you as an individual, but certainly always give it a thought. But there are big changes ahead. We've already seen 2 treatments here that we're using in England. There's 5 in the States, and these ones are going to be making their way over here very quickly. But it is confusing, as I said. You guys are probably going away thinking, I can't remember any of those names, and I knew there was this and that, but I know there's 14 of them. Most kidney doctors haven't got a clue about most of this either. So we're doing a lot of educating to our nephrology colleagues about these new treatments and how they should be used in clinical practice.
If all the drugs are successful, is the potential outcome still irreversible damage?
No, I genuinely believe that if we have access to these treatments, we will get the loss of kidney function back in a patient with IgA nephropathy back to what we see in a healthy person. The question then comes, can I get you early enough? Because healthy people do lose a little bit of kidney function as they get older. And if I've got you too late and I turn off the disease, you're still going to lose a little bit of kidney function, because that's what healthy people do. And if you're close to dialysis by the time I get you, I'm not going to be able to stop that. So that's why the imperative becomes, we've got all these wonderful treatments. I think I can get your kidney function loss back to what I see in a healthy person, but I need to get you early enough so that you can live till you're 75, 80 and never have to know what a dialysis machine looks like. So that's where we're starting to think about making sure we get people early enough.
And this is a real leap to the future, but is there any chance of being able to reverse the scarring? So you talked about the inflammation, and my understanding is if you attack it, you can, reduce the inflammation, and that will save function and prolong the working kidney. Just in terms of, scarring, so the liver, for example, will grow.
Yes, so unfortunately, once you've lost a nephron, a filtration unit, we can never get it back. Unlike the liver, I could cut half your liver out and you could donate half your liver, and your person who's donated it, the liver will just grow back because the liver can regenerate. The nephrons can't. So once you've lost a filtration unit, we can't get it back, unfortunately. So we can stop further filtration units being lost, and we can halt the disease in that filter, so you've got some of the filter to work, but at the moment we cannot regrow or regenerate filters, I'm afraid. Yeah.
Are there any clinical trials stable transplant?
Yeah, so we've got 2 trials, as I said, with kidney transplants who have got recurrent IgA. Chike is leading one of those in Leicester. And are you going to talk about that? Yeah, so Chike is going to talk about that. And then there's another study. We actually have a couple of transplant recurrent patients who travel up from different parts of England in the trial that we're running here. And there's a couple of sites in the UK. And many of the drugs that I just talked about are now moving into recurrent transplant. It isn't somewhere that you would go straight away, because of course transplant patients are complicated. You have to have treatments to stop rejection. and we don't know how the drugs we're giving for IgA nephropathy interact with those treatments you're on to stop rejection. So it's a little bit more complicated. So we need to be confident the drug works in IgA nephropathy before we move it into transplantation. But it's definitely a direction of travel for many of these treatments. And I think many of these will be absolutely brilliant in the setting of transplant. So the future is exciting. The most important thing for you guys, as you've been bombarded with information, is let it sink in. We're going to go through some of this information again in some of the other talks, and please, please, please ask questions. So we'll have, what have we got? A few minutes for questions now. What normally happens at conferences is I do my presentation, and then I'm desperate to go to the loo for a pee. And I'm desperately going, and there's a big queue of people that weren't prepared to ask me a question. So anyone prepared to ask a question now? Because I guarantee you it'll be a question that's relevant to other people in the audience.
How extensive are the sort of training programs and being sort of reached out to with the hospitals and other nephrologists, as you said, that aren't aware of the treatments? Because I'm not a Leicester patient.
No, so we have something across the UK, which is called the Glomerulonephritis Clinical Study Group, which has representatives from every hospital in the United Kingdom, where we meet and talk about trials. And so we try and get the message out through that network. We try and get the message out through the things we're doing here. I think one of the important things Alistair mentioned is encouraging patients to be their own advocate. Because let's face it, we don't live in a perfect world with perfect nephrologists everywhere who know everything about everything. And I think it's unreasonable to expect a nephrologist to know everything about everything. We talked about a disease here. So we make about 30 to 40 new diagnoses of IgA nephropathy a year for a population of around 2 million. And there are about 40 nephrologists there. So every nephrologist on average is going to see one new case a year, mixed in with everything else that they see. I've just talked about 14 drugs here in one disease where they see one new patient a year. And there's similar things happening in lots of others. So what you need is a nephrologist that accepts they know what they know. And if they're not comfortable, they phone a friend. And that's where I think we're going to be getting to in terms of not expecting every nephrologist to know everything about everything. They may be great at dialysis, may be great at transplant, may be great at diabetic kidney disease. But if you're not getting what you need, is to ask them, could you have the advice of someone else? And that may be someone locally. So within Manchester, I know 2 or 3 guys that we work very closely with, or it could be somewhere further apart. I mean, a quarter of my clinic is talking to patients not from Leicester. So it can happen, but I think we do need to accept, and but we don't live in a world where your kidney doctor is going to necessarily know everything about the disease that you have, because there's just not enough time in the day to actually know all of that. But we're a very friendly bunch. Honestly, I've never had a problem with any nephrologist ever getting upset that someone's been referred to me or Chike to ask what the heck should we do next. It's not a problem. So don't feel shy if you want to ask for someone to have a chat. And for the clinical trial side of things, I mean, I don't know, Mark, whether you want to say, but you're not in Leicester, are you? But you're in one of our clinical trials.
My nephrologist is just out to retire. And I was talking to him a month ago, and we were discussing the fact that when he retires, I will probably become the IgAN expert in the room when I go to my next appointment. And that's something, as a patient, you've got to start to really understand and appreciate.
I go to the States, and you fly from one coast to the other, and for the same flight journey, if you flew east from the UK, you'd be well into Asia. We're a small country. I have people coming up from Portsmouth. I had a guy who used to come down from Glasgow. If you're in a trial, all expenses, overnight accommodation, everything is covered. It's about whether you have the time and it's practical to do it. I mean, I know, Mark, you travel up from Hereford and you come up early in the morning. We're a small place, we're a small place. So there are opportunities. They may or may not be practical at certain times in people's lives because there are other things going on. But, you know, I think COVID was a horrible time, but it liberated us into things like Teams and Zoom. I mean, I have Teams meetings with patients in Pakistan, Dubai, wherever. So there's opportunities to gain access to advice and guidance. And many clinics are now set up in the UK to allow us to do that. So we do need to get the message out there that actually there are opportunities to get the information that you need.
Hi, John. Have you got any advice on for patients that I've got 22 EGFR now, so sub 30? Any advice other than you're too late?
No, I think we need to be realistic. You know, you're only 21, so we've got to think about the next 50 years. 20, we're keeping that at 21 forever is going to be a challenge. This may not be impossible, but 20 to 30, you've got the opportunity of being in clinical trials. We've got these new drugs coming, got the opportunity of thinking about a right combination to keep that GFR at 20. So there are opportunities, I think. We're never going to get that 20 back to 100 or 50 because we just cannot regenerate the filters. But with the tools we have available at the moment, if we manage this, we can keep that as close to 20 as possible for as long as possible.
Thank you. Just, I guess, against the backdrop of early detection being really important, and listening that, you know, your average nephrologist might not be an expert in IgAN, what chance have the GPs got, and what guidance are GPs getting in order to increase the early detection? Because a lot of patients I've spoken to feel that perhaps the early detection in the initial GP consultations, you know, isn't where it needs to be at the moment.
That's very true. And again, that's something you guys are wrestling with in the States. So one of the things we want to raise awareness is if you dip the urine and you have blood and protein in the urine, the most common thing is you've got a urinary tract infection. But actually you need to think, is it that, or is it in fact a sign of underlying kidney disease? So this is all around education. So it's about educating GPs that this is going to potentially be something they need to think slightly differently about. We also need to get GPs to dipstick urine, to be honest. And we need our colleagues in other parts of medicine to dipstick urine and not to also think it's a urinary tract infection. So we have a massive, massive amount of work to do to educate. But I think we can, rather than educating to say they're bad doctors, they're not doing it right, the message should be, we now have wonderful treatments. Imagine the opportunity of detecting early kidney disease in a 20-year-old. We can revolutionize their life if we get the referral. So spin a very, very positive message that actually now we desperately want to see these people because we can do something transformative to protect their kidneys. So this is work that we're doing in many, many parts of the world, thinking about how we get that message out to not only primary care GPs, but also the gastroenterologists, the urologists, the obstetricians, everyone, to get them a real positive message out. You pick the patients up early, we can transform their lives.
I'm an IgA patient. I found it very interesting to learn the antibody lives or comes from the mucosal system. And I've always had sort of overactive production in that area, like postnasal drip and such, always coughing. Is there any connection?
So normally patients don't have obvious symptoms related to infection. But we're still only just starting to look at this. And some of the work that Ishika is going to be doing, as I say, is looking when there is a flare of disease, when we think everything that's happening within the mucosa is at its height. And then we can see patients when they're feeling completely well. And that will give us an idea of what's actually the big change between the two. Once we understand what the big changes are, we can look at them in the general population.
But mine's like chronic.
Yeah, I mean, we always have to accept that sometimes people are unfortunate enough to have two separate processes that aren't connected. And that's a challenge, is to work out in a rare disease what's a true association and what just happens to be bad luck. So again, we just don't understand enough about the mucosal immune system to know whether they are truly connected or not. The only way we can do that is with the experiments that we're kind of planning and doing.
I was just wondering, is this something you're born with, like the defective IgA, or is this something that just can happen as you get older,
So,
if it's to do with antibodies?
so there are what we call genetic studies that look in thousands and thousands of patients to see what's different about the genes in patients with IgA nephropathy to patients who are healthy. And there you can see there are a whole range, I think there's now 40 or 50 different genes that may be subtly different in IgA nephropathy patients to people without IgA nephropathy. Each of them contributes a very, very, very small amount of risk. So there isn't a genetic test we can do, and it doesn't mean to say you're going to pass the condition on to your kids.
That's my second question.
Yeah, so that no, there are certain families with a very, very strong family history of kidney disease and IgA nephropathy, and we don't quite understand what is there. But for the general population, it's not something that you'll pass on to your kids.
So would it not be worth? I've got a 3-year-old now. I'm not saying to get him tested, but would it be worth at some point getting, not obviously not a biopsy, but like kidney function, and just look like, or it would just look out for symptoms? I'm just very concerned.
So I would not recommend screening, but if 2 or 3 times a week that's always on your mind, it's the easiest thing in the world to get a child to pee into a pot and do a test.
Yeah.
But I would not be recommending formal screening
No.
because there's no risk,
Okay.
really. What I was getting to is that there is a people will have not everyone has all of these different genetic changes, but there will be a genetic background here that you're born with.
Yeah.
And that may determine the development of the disease. And we think that it's also an interaction with the environment, and particularly things that you meet in terms of infections, the bugs that actually live in your bowel normally. Everyone has lots and lots and lots of bacteria that are very happy at home in your intestines and in your lungs. And in fact, Chike, are you going to talk about? Yep, so Chike has just done a study looking at how we might change that. Could that be a new treatment? Change the bacteria that live inside your guts, because the gut and the bacteria are continually talking. Could that be part of the reason that patients develop IgA nephropathy? And one of the interesting things is that IgA nephropathy is relatively rare, and in the West, in North America and Europe, it's very, very common as you move into East and Southeast Asia. 1 in 4 people on dialysis in China is on dialysis because of IgA nephropathy. And there are more people on dialysis in China than there are in the whole of Europe. It is a very large problem. And one of the reasons is we think the genetic mix is different, and also the environmental exposure in terms of the bugs they have to deal with, what they eat, environmental pollution, etc., is also interacting. And that's what's driving. But we don't have a precise cause in an individual person. It's likely a combination of things.
Just a easy one first. My nephrologist was intrigued when I told him that I was coming here, and said I've sent him all the information that I know. Do you have a card that I could send to him? He was keen to get in touch and reach out.
Yeah, we can chat over coffee.
I was also a bit intrigued again as a mum, and the genetic thing, because my husband's cousin has IgA and myself. And then you do start wondering, genes on both sides. So yeah, it was just.
Yeah, so there's a very interesting study from a place called Birmingham, Alabama, where there's someone called Bruce Julian, who from very early age stages identified these big families in Kentucky that had strong family histories of IgA nephropathy. And he was able to trace those families back to 2 people that left Scotland, wherever many years ago. And then they moved into the US, and their families had a very high incidence of IgA nephropathy. But interestingly, even though you've got families where there's lots and lots of people with IgA nephropathy, we haven't been able to find the genetic cause. And there you would imagine there's a massive genetic contribution because it runs in families, but we haven't been able to find it. But generally, for most people, so for 95% plus of the patients I see, there is no family history, there is no risk, or the same risk as the general population of children having IgA nephropathy.
Hi. Before this session, the last one I went to was one that I think was held in London, the Wellcome Institute.
Oh yeah, gosh, good
So that was
memory.
some time ago.
Yeah.
And at that point, I heard a presentation by you where you said there's still lots of things we don't know. And one of the things you said, we thought that IgA might be a disease of the gut.
Yep.
And there's a danger obviously in sort of relating things to just two examples. But in my example, the thing which seemed to trigger my rapid function decline was an operation. I had a hernia repair that involves your intestines. And you say that IgA is a rare disease. I've got a friend in Leicestershire who also has got IgA nephropathy, and the thing that triggered a very rapid decline in him was an intrusive sort of operation which involved his intestines. So in my mind, I think you've got sort of like a genetic predisposition to something, and you've got a trigger. Is it still the case that you think that quite a lot of the answer might be to do with the gut that you said a few minutes ago?
If you look at all the genetic studies,
Yeah.
and what we do is we look at what's different in patients and different in healthy people, and we find all these different genetic genes that are involved, and we then say, are all these genes involved in lots of different processes in the body? You know, is it random? Or are they all involved in very similar processes in specific bits of the body? And you're able to do that with modern technology. And what we find is when we look at all these different genes that we've found, they all are associated, or majority are associated, with how you produce IgA within the gut. Or they're associated with how the mucosal immune system works. And some of those genes are also found in people that have inflammatory bowel disease, such as Crohn's disease or ulcerative colitis. So there's a very clear signal that something is happening within the immune system, within our gut, that is driving or making you predisposed to IgA nephropathy. And what's interesting here, so I'll be interested what you think. So we like to study humans rather than laboratory animals, and we like to get samples. And so we've done studies where we have had people have an endoscope through the mouth. We've had studies where we've collected bone marrow. So I thought, wouldn't it be great if we could have patients might consent to having a colonoscopy up the bottom so that we could actually sample the immune system of the gut. And so it's amazing what people put on YouTube. I went on YouTube and I said, could I have and I looked for the most distressing recording of someone taking the bowel prep. Yeah, I know, but someone filmed it. And then, not in graphic detail, but enough detail. And then I found a video of someone who filmed their own colonoscopy. I thought, why would you do that and put it on YouTube? But anyway, they did. And so I put it on the UK Facebook channel, and I just put out to the patients, I want to do this procedure. It would be a research procedure, won't impact on your IgA at all, but I just want to get bits of bowel to study in the lab. Would you be interested? But you have to watch these 2 videos first. And actually, within about 6 hours, I had 10 people that said, yeah, I'd be happy to do that. So we are, GK, you're going to talk about, perhaps not, but we are going to be doing this. But actually, I worked with some Chinese nephrologists who've already done it. They convinced a whole series of Chinese patients with IgA to have endoscopies. So we've now got the secretions that come out into the gut. We've got biopsies of their immune system of their gut. We've got the blood, what's happening in the blood, and we can relate all of those. And it's really backing up what the genetic studies have shown.
I was moving away from the payer patch.
Well, the Peyer's patches are important. These are structures within the gut immune system where all the exciting stuff happens in terms of these B cells becoming activated and then generating the IgA. And so those are clearly still very important. But what we're trying to do is really understand what that means in terms of patients and whether that identifies new ways of potentially treating the disease.
Talking about this gaps where this comes. So I've been always thinking, obviously with patients, I've been patient for 19, 20 years. And I literally did privately, because you can't do it on NHS, my own private gut microbiome test just to see what's in there. And then even more recently, I read that there were tests where basically they were testing to do FMT transplant with patients. FMT stands for fecal microbiome transplant.
Yep.
There was some studies in nature.com, basically, you can read about this study. Is this something as well that as researchers you are looking at?
So there are two studies from China. So this is where you collect feces. Okay, imagine this in a bag, NG tube. And so it's used for, if you've ever heard of something called C. diff, Clostridium difficile, very bad infection that you can get in hospitals, causes lots of diarrhea, and you get a fecal transplant, which repopulates your gut with good bacteria, and it's very highly effective. And they've tried that in IgA nephropathy as a way of altering the bacteria in your gut. My guess is, I'm not sure many people will be sticking their hand up to have that. But you can have capsules now, and there's been some studies of that. And you can look at studies of probiotics, which Chike will talk about, that we've been looking at. So I think it's a really exciting area because you can potentially alter the bacteria that live in your gut, and that could potentially have a positive effect. I'm not sure it's going to cure the disease, but it may well have an additive effect. The real challenge, as we know with any lifestyle change, because of course, the bacteria are determined by what you eat as well. So if you're vegetarian, it looks different to a carnivore. You drink Diet Coke. There's a great study, just drinking Diet Coke completely changes your gut microbiota. So lifestyle modification can achieve that, but maintaining lifestyle modification can be a real challenge. But there's lots of exciting things happening related to the gut that could potentially change the way we think about it. But Chike is going to talk about that in the study that we've done here in Leicester. How are we doing for time? Okay, right. Well, thank you very much. Please, again, ask questions. We're very happy to talk about feces as much as you like, okay?